Ah. Oh, God. Readings, we start in about 20 minutes. Hello, testing 1 2, testing 1 2. Hey, Sharaf,
Hi, John.
how you doing?
I'm good.
Don't worry, there'll be more people. It's early.
Yeah,
So you're at home?
I didn't get you. Sorry.
Are you at home?
Not really. I'm not at home. I'm at my what you call this rented house, rented room.
Oh, okay. Are you in Sri Lanka, right?
Yeah, in Sri Lanka. Yeah, that's right.
Okay.
Can you give me a few minutes?
Yeah, sure. We have at least 10 minutes. Don't worry about it.
Right, sure. Okay. Thanks.
So,
Can you hear me, John?
yes, I can hear you. I just
All right.
trying to do some things here.
Okay. How are the things? A bit busy, isn't it?
Hold on. I got confused there. I'm sorry. Let me get my camera on here.
Sure. Yeah, we can see you now.
Yeah. Yeah, near the beach.
Yeah.
I'm sure Sri Lanka has great beaches, right?
Things are a little bit calmer now.
What
Getting
is
a bit better.
Oh, okay, but they have beaches in good beaches in Sri Lanka.
Yeah, of course. There are a lot of very nice beaches.
What kind of sand is it? Is it dark sand?
It depends. Now, when you go to eastern province or northern province, you have very nice, like shallow water, sandy beaches. It is very clear. It's not very deep. So the best beaches are there: Trincomalee, Nila Valley. So
What part of the island is that? South, east, west?
that is eastern province.
East.
Yeah, in down south also you have nice beaches in Gaul, Hikkadua, Miris, where you have whale watching as well. So lots of beautiful places.
Oh yeah.
But I think the best beaches are in Trinco, closer to that area in the eastern province where I used to work before in 2019.
Oh, okay. So the hospital you're at now, what part of the island is that at?
Sorry, I didn't catch that.
The south part, I mean, the
Yeah.
hospital you're at now.
No. Now I'm in the Sabaragapo province, which is famous for, gems.
Gems, okay.
Yeah. So it is
What kind of gems come from there? Rubies?
rubies, blue sapphire. I mean, all types of gems.
Yeah, it's
Sri Lanka is
funny.
famous for blue sapphire.
Blue sapphire, okay, yeah, it's funny how different parts of the world have different resources.
Yeah.
That I was surprised. Where's that? Dominican Republic, or I think it was the Dominican that has some kind of jewel that no other part of the world has it.
Yeah,
I
that's
think it's
right.
Dominican. Yeah, it's funny.
You got a busy schedule today, isn't it? Ahead.
I'm sorry.
You got a busy schedule ahead, is it? Very busy schedule ahead today, is it? So many webinars coming up today.
Oh, busy.
So?
Yes.
Yeah.
Yes. We have one. This is our first one today. Usually we have one before. We have one from Venezuela at 6.
Yeah.
And Nicaragua at 9.
Yeah. So I will try to wrap up in
no, there's plenty of time.
One hour and 15 minutes time.
Yeah, that's fine.
Actually, I had my presentation prepared for a few aspects like brain and spine, but I thought of only discussing brain today. So I will discuss spine cases on another day, 1 hour. So
yeah, well, let me tell you what I'm doing here, because we won't be in a hurry. Wait a few minutes to start. But what I'm saying that works is to have a webcast every 2 weeks. Like,
okay.
I call it grand rounds, just like we're doing today. And it could be any topic you want. It could be a case presentation. And now I'm saying it's better just to do one, because it's hard for people to put together a couple of people, for grand rounds every 2 weeks.
Yeah.
But if they just get one talk, I say that's a grand round, whatever.
Yeah.
So if you want to continue that in the future, just let me know.
Yeah, sure.
We'll try
I can do I have so many spine cases, so I can do so many spine cases actually I prepared. So let me know. So
yes,
I'm
yes.
available.
If you don't mind, it won't be Friday, because Friday's a really busy day.
Yeah.
If we can do another time, a Thursday,
No
Tuesday, Monday.
Yeah.
And we won't have a lot of people, but we can make it grow.
It doesn't matter. Better if you can have it after 8 p.m. IST. Is that okay with you?
Yeah, that's fine. During the week, anytime.
Okay, that's great.
And, you know, like I said, we won't get a lot of people, but it's okay. We'll continue it and we'll grow. And it'll allow you to keep touch with the academic world. So, yeah, well, because I was thinking of that. And we can make this grow.
Sure.
And any way you want. If you want to do a case presentation, the didactic, and on, you like spine, right?
Yeah.
Okay. You specialize in spine, or is it?
No, we do general neurosurgery, but mainly I'm interested in vascular and spine. So
okay,
because we get a lot of spine cases, because more than 50% of my workload is spine.
Really?
Yeah. So many. It's like a spine center, even though I mean most people recognize it as the least developed neurosurgical center in Sri Lanka because it's recently established. But I think we do so many spine cases compared to the other centers.
Is that
because
like
so many falls from heights, fall from trees.
Very mountainous place. Very mountainous place.
Yeah.
Fall
from heights, fall from
Greece
trees.
is the same way. Greece is
so many spine fractures.
Well, I don't know if Sri Lanka's like Greece, but I would be scared if I came. When I went to Greece, I was scared because they have these roads that go on these mountains. They're right at the edge.
Yeah.
Is that the same in Sri Lanka?
No, not like that. But people here, there are so many, their occupation is as such. So they climb the trees, they climb, there are so many mines, so they fall from the mines, these gem mines.
Right.
So that is actually occupational hazards, actually.
Oh, okay. Munsingi, that's how you pronounce it. That's interesting. I'm sure you've developed a reputation as a spine guy.
We'll see how it goes.
Okay, you ready to start?
Yeah, I'm ready.
Okay, 10, 9, 8, 7. Let me make sure I get everything set. I always screw up. 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. And today we have the honor of having what we calling Sri Lanka Grand Rounds, Neurosurgery Grand Rounds. I guess this is the first one with Sarath Munsingi, a neurosurgeon from Sri Lanka. He's given a couple of webcasts before, and we may even make this a regular thing on a weekday. So, well, okay, we welcome Sarath. Welcome, it's all yours.
Welcome, John. Thank you very much for giving the opportunity. So, good morning or good afternoon, good evening, wherever you are. So today we are going to talk about on the topic of problems and challenges we encounter as neurosurgeons practicing at the periphery, and the lessons learned from those complications and challenges. So today I will mainly concentrate on a few aspects, mainly the brain. And next couple of times we'll talk about some important and interesting spine cases. So let me share my screen. I hope everyone can see my screen. Is it visible, John?
Yes, it's good.
Right. Okay, so today we are going to talk about some controversial and interesting aspect in neurosurgery, which is regarding supratentorial deep-seated ICH. So deep-seated basal ganglia ICH mainly. So I'm going to talk about the keyhole approach, keyhole craniotomy for these supratentorial deep-seated intracerebral hemorrhages, because it's being a big challenge, and sometimes actually a big problem for us because of so many limitations and so many drawbacks and so many challenges as peripheral neurosurgeons in a resource-poor country like Sri Lanka. So I think I have gone through this before as well. So I will make it short and sweet. So these are the challenges we face every day. Because in our setup, the mortality is actually more than which is mentioned in the literature, maybe around 60 to 70%. The reason behind this is multifactorial because we don't have proper care, especially the HDUs and ICUs to look after these patients. And sometimes most people do not know the true definition of conservative management because most people say when you call it conservative management for a intracerebral hemorrhage, which doesn't require surgical intervention, they perceive it as doing nothing, which is wrong. And a very important point is we are unable to identify the point of deterioration for these patients because of the lack of the proper care. And we don't have apparatus available to measure the intracerebral pressure in our setups. And for example, in my setup, I don't have a proper ward even. So it's being very difficult because these patients being managed at different places, mostly in the medical wards and sometimes in the general surgical wards. It's causing a lot of problems. And the other problem is lack of theater time. Sometimes we don't have a dedicated 24-hour theater for us to operate if the patient deteriorates at that point of time. And we don't have post-op ICU and HDU care, which is very, very troublesome for us, causing so much stress. And sometimes surgery with general anesthesia is not possible because of lack of anesthetist. And more importantly, we don't have a proper rehabilitation pathway in Sri Lanka, causing so many problems, social problems, and lots of financial in every way, in every way. So many problems and post-op complications also. And we know the most people die not due to the intracerebral hemorrhage, they die post-operatively mostly due to chest infections, post-op aspiration. So I decided to find out a way of overcoming some of these problems at least. Initially, I used to operate these basal ganglia ICH with a big craniotomy when I was a trainee. But after some time, due to these constraints, due to this lack of infrastructure, I thought of doing it with a keyhole because of these reasons. Because it's quick, it can be done quickly because time is a limiting factor for me. And sometimes it can be done under sedation or local anesthesia because anesthesia is a limiting factor for us. And most importantly, I have observed acceptable, favorable outcomes with this approach due to the minimal morbidity of the craniotomy and the less duration it takes to do the case. And also, in sometimes post-op ward care is possible in selected patients because of lack of ICU and lack of HDU beds to send these patients post-operatively. So, for example, my hospital is a teaching hospital. I'm the only neurosurgeon. We get around 4 to 5 cases of this basal ganglia ICH per month. So for around 50, 60 cases per year. And we do around 4 to 5 cases. We operate every month. And most of the time we don't have post-op ICUs or HDUs. So most of the time we have to send these patients to wards prematurely, and we had to do a tracheostomy for these patients. So this is this case I'm showing you as the first case because this was the inspiration to me to start this keyhole approach. This was in December 2019. This patient, 60 years of age, female, presented with this left-sided ICH with a GCS of 8 initially, which dropped to GCS of 5. And this patient was on warfarin. And at that time, we did not have an ICU bed, and we didn't have an anesthetist to operate this patient because this patient was deteriorating. I decided to operate, but the surgical casualty was going on, so we didn't have a theater to operate. Not a theater, actually, we had a theater, but we didn't have an anesthetist. So what I did, I asked the general surgical casualty anesthetist to just hang around if we need you, because we are going to do it under local anesthesia, a little bit of sedation. So we did this case with a little bit of sedation and under local anesthesia. And I did a mini craniotomy and removed this clot. And so you can see clearly it's on 20th of November. And this is on 20th, this is on 21st, this is immediate post-op after 24 hours. So this is the post-op CT. We corrected the coagulopathy in the ward. And this is just to show you the exact date. It's 20th, and this video was taken exactly after 2 weeks. And you can see she was walking absolutely fine. So that was a remarkable recovery for her. So that was the inspiration and stimulus for me to start routinely doing this intracerebral hemorrhage, whether it is superficial or deep, in selected cases, right? I'm using that word, selected cases, routinely. So then I kept on doing all these cases where I realized that there is no harm or there is no threat of going in with a keyhole, because we did not have, when I was working in the previous center also and in my present center also, I don't have the routine facility of doing CT angiograms for all these patients. So you had to clinically decide whether it's just a hypertensive ICH or whether it's a vascular malformation. So you had to be ready. I had to be ready with whatever the armamentarium, if it was an aneurysm or an AVM. But luckily, I'm very selective. I'm highly cognizant about that. So it didn't happen frequently except in 4 or 5 cases. So this is the second one I did with a small keyhole craniotomy. But you can see there is some subarachnoid blood here. So I was thinking whether it could be arteriovenous malformation or aneurysm, because I didn't have the facility of getting a CT angiogram done because this patient deteriorated. And this is the second case. I was doing keyhole, and it proved to be a arteriovenous malformation. So I had to convert it to a little bit bigger craniotomy, and I did the resected the AVM. So I was a bit upset at that time because it was the second case I decided to do routinely with a keyhole, and it happened to be an AVM. But I didn't stop at that. So I wanted to be more precautious thereafter in selecting the cases, and I kept on doing that. So you can see this again done with a small keyhole craniotomy. So all these patients I'm showing you went home, discharged and went home and still alive. So all these patients, according to the modified ranking scale, either having moderate or mild disability, not bedridden. So I'm showing you the images of the selected people who are still having a good or a better outcome. So you can see as the time progresses, the size of the craniotomy reduced. This is another case, right-sided. So this is the size of the craniotomy. in the initial period, early days of my career of doing these ICH evacuations through the burr hole, I used to leave the bone flap out. I did not keep the bone flap, but then I realized you can keep the bone flap. There is not much not much cerebral edema, even though you keep that small bone flap floating. So this is another case. You can see the bone flap, a very small craniotomy. The size of the craniotomy getting reduced and reduced with time. Yeah. So these cases presented with a GCS of more than 8. So the cases I have shown you up to now, those cases presented with the GCS of more than 8. And this is another case, initially presented with the GCS of 12 and then dropped. So this is the initial CT. This is the CT after 48 hours where the hematoma expanded, and then again operated with the keyhole approach, and he went home. So yeah, so this is post-op day 10. You can see there is not much of edema, not significant edema. So you can see the bone flap is floating. I have not fixed the bone flap, but it's not, I mean, there is not such pressure to cause it go away. Right. So let's talk about some indications in my setup. So in my setup, mainly clinical deterioration is the key for me to decide whether this patient needs surgery or not. And also we intervene if the presenting GCS is less than 9, and if the hematoma is more than 30, or if there is a sudden drop in GCS of more than 2 from the initial GCS, which correlates with the expansion of ICH radiologically. So usually clinical deterioration, which correlates with the radiological expansion, we decide to operate. So all these criteria, midline shift, the volume, which is measured with the CT. And in my setup, since it's a poor resource country, poor resource setup, I usually do operate on patients who are less than 65 years of age. But no hard and fast rules. Mainly we go with the biological age. Right. So here are some technical considerations for you. So the most important for us as peripheral neurosurgeons in resource poor setups, the craniometric point measurements, because we don't have navigation available to identify the entry point and to decide the trajectory. So identification of the entry point is very, very important, because we use it as a fulcrum to move in all 4 directions. And the entry point, it differs depending on the hematoma location. But roughly, these are my guidance, which determines the entry point. Closest to the surface, most of the time, causing less damage to the iliac cortex, and the trajectory where the trajectory is easiest. And usually in basal ganglia hematomas, we know we use the middle temporal gyrus to make the cortical window. So the entry point, as I said, it's the fulcrum, because it's a very small opening. You put your bipolar in and you have access to all 4 directions. And it also determines your trajectory. So I would like to make the entry point usually in the superior third of the hematoma, in the sagittal plane. If you take the sagittal plane from superior to inferior, I'd like to use the superior third. The superior 1/3 of the hematoma. And in the coronal plane, I usually prefer the posterior third of the clot or the middle of the clot. For example, you can see if this is the head, say this is the left-sided hematoma, so this is the hematoma. So So if you divide it into thirds, this is the hematoma. So I would like to get my entry point at the posterior third and posterior and the superior third, because the natural angle for any surgeon is to go down and to go forward, to go anteriorly. So if you go in a trajectory from superior to inferior and from anterior to posterior, it is easier for you. If you start from a little bit lower point, then you have to get the superior clot. You have to turn the head and you have to turn the microscope, a little bit cumbersome. But if you start from above as much as possible, going down and anterior is not difficult, because sometimes we do operate in these patients under local anesthesia. In that case, the patient is not on pins, so it is difficult to manipulate the head and it's difficult to manipulate the table position always. So that is one advantage. So for example, you can see you can turn the head to 30 degrees, 45, 60, whatever the position. So what I mean, if it is the hematoma going in this direction, if it is left side, if it is right side, going in that direction, from superior to inferior and from posterior to anterior is easier. So talking about the trajectory is very important, and it depends on the size, the shape of the hematoma, and the extension of the clot. As I said, usually posterior to anterior and superior to inferior is preferred. Why? Because of these reasons. It is the natural angle of a surgeon. It doesn't mean that you can't operate. You can't start from a different entry point and operate. You can, but this is the easier way. And we have to pay special attention at the medial and the anterior aspects where the origin of the bleeders are. So we have to be extra precautious at that level, and we have to be ready to visualize that end. And if you want, you can leave a little bit of clot there to prevent rebleed. So going towards the area of importance with better visualization. Again, superior to inferior, it's the natural angle with head position. So, or otherwise, if we have to go more in the direction of superior from inferior, then you have to adjust the table, which is a little bit cumbersome. I won't say difficult, but cumbersome. And as I said, patient not on pins and turning the head is limited. This is one example I can show you. So I showed this before. So this is in the earlier part of my career. So you can see my entry point is a little bit lower here. So I had to come all the way up and also down. So I have entered from here. So I had to go down inferiorly as well as I had to go up considerably. So you can see some amount of clot is left, but that's not a problem. As I always say, you don't need to take the whole clot. You don't need to take the whole clot out. You can take, even though you take 80%, 85%, 90%, that's not going to be a problem. Right. So talking more about the technical aspect, I usually use a 3 centimeter to 5 centimeter straight incision. Straight incision always slightly bigger than the burr hole I make, and dura incise with a cruciate fashion and make the cortical window, as I said, could be transchiral or transsulcal. If it is transsulcal, you encounter the blood vessels. So I prefer transchiral. So be ready to move the microscope in all 4 directions if needed, and change the table position if needed. So mainly my armamentarium includes the sucker and the bipolar. And sometimes I use rongers if the hematoma is very thick. But nowadays I don't like to use the rongers as well, and retractor forceps if needed, but I never use fixed retractors to minimize the damage to the adjacent brain parenchyma. And usually the whole procedure takes 45 minutes, sometimes 1 hour, depending on the size of the hematoma. So I always spend 10 minutes for the hemostasis, which is the most important step in the whole surgery. And as I said, I keep the bone flap floating if needed. Right. So let's apply these whatever being said practically in a real case scenario. So now I'm showing you the cases which presented to me with the GCS of less than 8. And you can see here all these hematomas I'm going to show you are left-sided basal ganglia hematomas. And all these patients presented with the GCS of less than 8. And all these patients went home and still alive. I'm still following them up with mild to moderate disability in the MRI scale. Right. So I'm showing you the left-sided approaches because not because I don't have right-sided cases, because you know the left side is the dominant side, and we say the prognosis is not very good compared to the non-dominant side. But let's see how it has gone up to now. So this is a case where I use the entry point closer to the surface. So you can see the case, the CT here. So it's extending almost towards the vertex. It's large hematoma. And I could have entered from a point here through the middle temporal gyrus, but I instead, I selected my entry point a bit higher, close to the surface, because then, you know, I don't have to go above from below. I just have to go in deeply and then lateral medial and anterior posterior. So you can see the date, 10th of February 2021. This is the immediate post-op on 11th of February 2021. So this is the post-op. Right. So this is what I do. So as I said, this is my entry point here. Mention number 1. I make a small hole and go directly down. I attack the hematoma directly inside the cavity. And first, I take the lateral aspect of the clot out. So initially, little bit of debulking of the clot and let the clot come towards you. Don't go chasing the clot, and remove the, get rid of the lateral aspect, debulk it, and then go down again and posterior. So first lateral, then posterior, and then finally go to anterior as you go deeper, and finally come to the medial aspect, where the most important structures are and where the most probably the bleeding originated. So be ready to leave a little bit of flimsy layer of hematoma at the anteromedial aspect. So go in lateral, posterior, anteromedial. That's what I do. So let's see the video of this patient. So this is the opening, slightly larger than the burr hole. I'm sorry about the quality of the video. The quality is not very good. I don't have much instruments. I usually have the fine scissor. I just have one fine scissor, one micro scissor, and this micro dissector and this hook. That's all I have for all the whatever it is, whether it's an aneurysm, whether it's a TP angle, tumor, ICH, that's all. And we don't have the finer suckers as well. Most of the time, the suckers are a bit rough on its edge, can damage the surface as well. So I'll fast forward due to the time constraints. So you can see there is a lot of edema. So made the cortical window and directly go in, very small cortical window. And as it was coming towards the cortex, so it's a superficial aspect of the hematoma is entered, and then you go down. So first you attack the lateral aspect of the clot. That's the lateral aspect of the clot. So you can see on my left hand side is the medial aspect. Where the bipolar is now is the lateral aspect, and where the sucker is now is the posterior aspect, and this is the anterior aspect where my the pointer is. This is the left-sided approach. So I'll just fast forward it. So now you are in the hematoma. Going to the posterior aspect. You can see, even though I use the bipolar, I don't activate the bipolar. I use it as an instrument to pull the clot very gently with the sucker. So very slowly get the clot out and let the clot, let the rest of the clot come towards you. And finally, you reach the anterior and the medial aspect. You need a lot of saline irrigation if the clot is tough. Don't vigorously pull. Sometimes I used to get the clot with the rongers if the thick is very thick, as in this occasion. But nowadays, I seldom use these rongers to minimize the trauma to the rest of the brain parenchyma, which could happen inadvertently. So this is a very tunnel vision. So you have to get used to it. When you get used to it, it becomes very easy. Initially, it is difficult technically because you are looking through a tunnel and you have to move and you have to go in all the 4 directions. Otherwise, you will end up in removing only 30 to 40% of the clot. So you have to think about the extensions of the clot. You have to have a clear picture, a 3D picture in your mind where the extensions are. And accordingly, you have to identify the clot extensions and take it out. And you have to be careful when you reach the anterior and the medial aspect. It's better not to enter the ventricle, avoid entering the ventricle. So I will fast forward it. So this is the medial and the posterior aspect. So you start from the posterior end of the medial aspect, and then you go up. Use the cottonoids regularly, frequently use the cottonoids. Very minimal diathermy, minimal bipolar, lot of saline. Usually what I do is when I reach the anterior and the medial aspect, I take a patty or a cottonoid and just rub the cottonoid along the walls of the hematoma to take whatever getting detached. And you can see small vessels, usually at the anteromedial aspect, where you have to diathermize carefully. So I will fast forward this. So these are the extensions right here. These are the extensions which are hidden. So you have to turn your microscope in all the 4 ways. As I mentioned, it is easy for you if the natural angle, you can see a small vessel here. If the natural angle is towards the anterior aspect from above downwards, it's easy rather than going the other way. Right. So let's go to the same operation. 30 minutes gone. This is the rest. This is the final part, the final aspect. Diatomizing the surfaces and then hemostasis. I don't have a tissue glue, so what I use is Surgiseal. That's all I have. So I started at 3 minutes time. See the time taken to achieve the hemostasis. I usually wait for a few minutes. So you can see it's almost, see, at roughly around 8 to 10 minutes I have spent for the hemostasis. So the surgery finished in 40 minutes time. So this is 10 minutes, 11 minutes, so plus 30 before. So it took only 15 minutes, 40 minutes time for us to finish the case, right? So that was this case. And another one, left side again closer to the surface, but not going all along up to the cortex. So I decided to again use a little bit of higher entry point, somewhere around here. Yeah, and went down. So this is the post-op CT. You can see the immediate post-op after 24 hours, most of the clot being taken out. This is the patient. He went home. He didn't want a tracheostomy as well. So this is post-op data, and you can see not much of edema there. So some people say you need to take a large bone flap out, but I don't think it is the truth always, right? See the bone flap just floating. Then post-op day. If you want, you can zoom it and see the date. That's the exact date. This is another case, but this was not, this is the initial CT he presented with. This is a 50 years old, I think more younger than that. Yeah, a patient was in 40s, as far as I remember. And this is the first CT he presented with a GCS of 11, but then it dropped to a GCS of 6. So definitely the CT, the hematoma must have expanded, but I don't have the CT at that time because we did not have time to repeat the CT because of the limitations in theater time. I had to take the patient to the theater and operated under local anesthesia. So this was done under local anesthesia. So you can see the trajectory here, right? Usually going from posterior to anterior, from superior to inferior. But this case, you can see, I have entered somewhere around here. So you go straight in, number one, straight in and go down, and then go posterior, go anterior, and finally medially. Right, so this is post-op day 12. We did a tracheostomy for this patient and he went home. Another case. This is a bit a difficult case because you can see it's close to the ventricle, the extension into the ventricle, secondary extension to the ventricle. These cases are difficult, and see the extension, see the shape, the regular shape. And this is the post-op. This is the post-op CT, where you can see I have not entered the ventricle. I have not tried to go inside the ventricle. So I have stopped there, and I have left a little bit in this aspect as well. So you have to know your limits. So you have to understand, you have to recognize where you are in the clot inside the brain. Otherwise, you will end up in causing more damage to the already compromised brain. As I said, difficult, more extensions, irregular. So we have to be cautious, don't open into ventricle as much as possible, and be careful at anterior and middle walls. So as I said, this was my entry point somewhere around here, and then go down, posterior. As I said before, the same principle. But remember, it's not applicable in all the cases because it practically, when you are within the clot, sometimes believe me, it's really hard to differentiate. So even though you say this, it's difficult practically sometimes, right? So entry point bit higher, go down inferiorly, laterally, posteriorly, and finally anteriorly and medially, right? This is the post-op CT. This is the patient post-op day 8. He survived and he went home. And this is these are the few cases I have done under local anesthesia. These cases, we did not have ICU beds, and the anesthetists were not very happy to go ahead with general anesthesia, so I had to operate. This is the initial CT, and this patient's GCS dropped. Again, due to the expansion of the clot, I don't have that CT. And we did it under local anesthesia. You can see when you do it under local anesthesia, it's difficult for you to take all the, to look for all the extensions and take the whole clot out. It doesn't matter. You take 70%, 80% of the clot, that's enough. So you reduce the edema, you reduce the toxic effect of the hematoma, the chemicals, and it has a fantastic effect on the patient's outcome. So this is him. You can see the right side, it's on the left side. He's walking and no weakness. This is day 14th. This is also day 14th. You can see it's 25th of August last year and 10th of September. That picture was taken. Another one, another case, large ICH. As far as I remember, this patient presented with a GCS of 5 or 6. And again done with a small craniotomy, keyhole. So it's not that difficult when you are trained to take such a big clot through a small opening. It's similar to endoscopic ICH evacuation. That's what you do through the endoscope as well. But here, what you do, you practice, you train your eye to have a tunnel vision. This is post-op day 5. So again, she survived. Now I'm showing you a few cases where the pre-op GCS is 3 to 5. So these are the patients in my list who presented with the lowest GCS. Now see the hematoma. You must be crazy to operate on this. But this was a staff patient. That's the problem with in our part of the world. Sometimes, most of the time, they want they like even their relative, their sister or brother, their father or mother. Even though the patient's brain is dead, if the patient is there physically, most of the times they are happy. So many. So much emotional. However much you explain to them regarding the outcome, it's in vain sometimes. So I had to operate reluctantly on this patient. And I did it under general anesthesia with a small craniotomy. So this is the post-op CT, you can see. This is after 5 days. I don't have the immediate post-op. Baby Nona, her name was. So this was so you can see it's a classic. The classic trajectory, as I mentioned you, starting from a little bit posterior third of the hematoma, going towards the anterior aspect, starting from above and going downwards. So it's a classic a case. Here, see the shape of the hematoma is also much feasible for that approach. Another case. This is the oldest patient in my case series. She was 78. I didn't know she was 78 because her age was mentioned as 60 in the bedhead ticket. We were told 60. So we were misled. Anyway, we operated on this patient and she survived, right? Because I usually don't operate on patients more than 65 years of age, because this is the natural way of, a one way of natural death for people. So by operating, sometimes either you hasten the pathway to hell or heaven, or you make it worse. So it's a very difficult decision to make sometimes, especially you are in a country and especially when you are working in periphery with minimal resources. So the pre of Jesus was 7 and dropped to 3. So this is her, this is the incision, and she survived. So let's see her video. Her name was Missy Nona. This is an edited video, right? You can see it's fast forwarded, I think, 10 times or maybe even more than that. I usually make the cruciate incision, not I mean, you can't say cruciate with the, I mean, more than 4 segments. So you directly go to the clot through that small hole you make. If you are in the correct position, if you are sure about your entry point, you are in there. You don't have to worry. See, I am taking the lateral aspect of the clot, again left-sided. You can see anterior aspect here, where my point is. This is posterior, that is medial, and this is lateral. Now the posterior aspect I'm taking. You don't have to worry at the lateral aspect. Usually, it's not always, it's usually. It's not a rule. That's what I have experienced. So I'm telling you with my experience, because nobody mentions in the book on how to evacuate an ICH. So it's your experience, and it's what you perceive, what you learn from your mistakes. So it's very important. So you can see I have used a retractor here. It's not a fixed retractor. I have asked my assistant to hold it for a few minutes. Minimal diathermy. Nowadays, I don't use the retractors as well. This is not the real speed, so it has to be very gentle. And finally, you go towards the anterior and the medial wall. I usually don't touch the, those are the extension I'm talking about. You can see those are the
Hey, John.
Yeah, I'm sorry, I had problems, audio problems.
Yeah.
Okay, you having trouble, Sarath? Oop, I guess he had into that trouble. Just stand by. Hopefully he'll be returning shortly. Hello, Ahmad. Greetings. You're muted, Ahmad. Unmute.
Hello, salam alaikum. Greeting.
Greetings.
Salam.
How are you today?
Thank you. Salam for our colleagues. I saw Dr. Taha and other colleagues, and I like to say salam in Muslim way. Thank you.
Okay. Okay. Yes. Saeed's
Yes,
here. Hello,
salam.
Saeed. How
Yes,
you doing?
salam.
Salam, salam.
Salam alaikum. Thank you very much.
Thank you.
How are you?
Fine, thank you. I'm from Afghanistan.
Yeah. Okay, welcome.
How you doing,
Okay.
Saeed?
Okay, Professor John.
Yes.
Yeah, as Dr. Surit presented, we also have this challenges and problems in Afghanistan as well. And as you know, we have a problem also with anesthesia.
Yeah,
Okay.
Okay.
I'm sorry.
You can ask him the question after. Okay. Welcome back,
Yes.
Sarath.
Yeah, I'm really sorry. My connection it disconnected because it's heavily raining outside. So sorry about that.
Okay. Same thing happens in Miami.
Oh, is that so? Right. Let me share your screen again. Right. Yeah. Right. So where were we were at? Yeah, we were here. Right. And yeah, I was showing you the video of the last bit of video of this patient.
Okay.
And let me show you. Right. Yeah. So I think we went somewhere around here. And so we are taking out the extensions, as I mentioned. These are the hidden extensions. Right. And right, that's it. Okay. Yeah, so this is her. And yeah, this case was done recently. You can see it's a large ICH. So most of you, if I ask you, 80%, 90% of you wouldn't have done this. But since it's a young patient, 45 years of age, and presenting with a GCS of 10, if you can see, the date was 1st of July. Patient present with a GCS of initially GCS of 10 and dropped to 5. Yeah, dropped to 5. 54 years of male, known hypertension. I took a chance and operated on this patient actually. His name was Pieratna. So let's see what I could achieve on this one. Yeah, this is again a fast forwarded video due to the time constraints. Sorry, I have, so it was a tough clot. So I had to use the Ranger reluctantly, though. You can see I'm taking the lateral aspect of the clot and then go to the posterior aspect. You can see now. Sorry about the poor video quality. Sometimes in my microscope, I have the problem. So this is the posterior aspect I'm taking out. Brain is pulsatile. take a little bit of clot out, and then go deeper and deeper, little by little. Take the inside of the clot out and let the clot come towards you. Let the clot come towards you. Don't go out of the clot and take it out as you are taking a meningioma. It's not possible. I mean, then you have a much tendency to damage the normal brain parenchyma. It's the other way around. From inside to outside. Leave a little bit of layer, if you want, on the anterior or the medial aspect. That is what I learned. And I had good outcomes with that. So you can see I make a very small, the opening. If I want, I extend it, even the dura. So this is the medial aspect. You're starting from the posterior region and going towards the anterior. The video quality is not very good here. Can't see much.
I don't know if it's the video. I think it's the internet speed.
No, I think it's the quality of the video, John, because
okay.
sometimes it's, yeah, it
Oh,
has
okay.
this, it causes this problem, yeah. So that's the video there. So this is what I achieved. So you can see, this is what I achieved. You can see the hematoma, 85 to 90% of the clot was out, taken out through that small hole. You can see the hole there, you could see it. And see the medial aspect and the anterior aspect. I have left a little bit of hematoma there. Perfectly okay. See the date. The initial date was 1st of July. Then I operated him on 3rd of July. And this is on 5th of July. So this is 48 hours after the operation. So this is in just single slide, the pre-op and the post-op. So sometimes it's, I mean, it's unbelievable that you can take this much of clot out through that small hole. This is post-op day 10. He had a little bit of superficial wound infection here. And see the, this is post-op day 10. Oh, I can't remember exactly. It's 16th of July, 16th of July. So it's all, yeah, exactly 10, 11 days after the post-op. Yeah, the bone flap is kept floating. You can see the edema is settling. So this patient went home with a moderate disability. So that is the largest ICH in my case series I have done so far. It's the largest, the volume of ICH I had, where most people would not have embarked on. What about IVH? What about intraventricular hemorrhage? So I don't have much experience in taking the intraventricular clots out through the approach, but I recently tried that out as well. So this is a young patient in 20s, in mid-20s, presented with the GCS of, initially GCS of 10 and then dropped to 6. I had to operate. We did not have the CT angiogram because we have run out of contrast due to the, you know, under the circumstances with the lack of resources, inflation, you know, the cost of living going sky high during the last few months in Sri Lanka. So what I did, I operated on this because you can see it is coming towards the almost the vertex. So let's see the video of this one as well, very short one. Yeah, and I knew that we came to know that he's a cannabis addict. So no worries, most probably due to cannabis rather than AV malformation. Fast forward it for you. Yeah, you are in now. See the size of the hole is very small. The Koch's point, where you would have inserted an EVD, the same hole I'm using, the same location, the same point. So you are inside the clot now. I'm not activating the diathermy. I'm just using as a guide to take the clot out. And now I'm activating a little bit on the lateral aspect of the clot. You have to be very careful. You have to be very careful when you're operating on intraventricular hemorrhages, because you have to minimize, absolutely minimize the diathermy, especially inside the ventricle and in the medial aspect of the clot. So again, sorry about the quality. So you take the clot out very quickly, and you have almost taken out the clot, and little bit of cauterization along the walls superficially. So the clot is out. 80% of time, 80% of the clot is out, and I took a biopsy from this edge because I had some suspicion about some abnormal vessels there. I didn't find out any obvious vascular abnormality, but I took a biopsy on that to confirm. And yeah, nothing much there. So that's it. This is the second part. Yeah, I took the I took the retractor and just checked all the walls. I made sure that I have not missed anything important. And finally, you achieve hemostasis and you insert the EVD through that, and that's all. Right. So let's see the post-op CT. This is the post-op CT, you can see. Right, so you can see almost 80 to 85% of the clot is out, or even the clot inside the ventricle is out, and the EVD is here. I had inserted an EVD on the right-hand side on the first day. So after I inserted the left side, we removed the other side and he went home. Another case, see the young patient in mid-30s, again extending to the ventricle, and see the opening, Koch's point, burr hole, through the burr hole, remove the clot. This is post-op day 1, and the EVD here. Again, he went home. GCS 15, no disability. Right. So this is the last one, this last slide. This patient, mid-40s, a female, presented initially with this hemorrhage, and her ICH expanded and her GCS dropped to 6, and I operated on her under local anesthesia. See, under local anesthesia operated, and this is her. This is the patient with the best outcome in my series up to now. She's walking, she's talking, she's back to work. She's working as an assistant in university. She can read, she can do everything. 95% back towards the normal life. So it's very satisfying. She still visits me once in a while as a gratitude. So this is what I did. This is my study. I'll quickly go through so we can wind up in another 5-10 minutes time. From 2019 June to 2022 August, I had operated on 144 cases of keyhole craniotomies for basal ganglia ICH. As I said, 5 cases per month. For the year, 60. And for 3 years, it comes around 150 to 180 cases. So 34 cases plus during the follow-up, 110 cases followed up for at least 3 months. So this is what I observed. So this is the pre-op GCS. You can see most of the patients are in the group of in the range of GCS of 8 to 12. So this is 23 patients with the GCS of 9 or higher than 9 to 12. And 38 patients with the GCS of 8 and 3 patients with the GCS of 3. Some of the cases I have already shown you. So side of the ICH, yeah, I don't know, fortunately or unfortunately, I had more left-sided ICH. So I have shown you most of the cases, 80% of my cases were left-sided ICH, 68, and right-sided 42. Out of all these thalamic ICH, I had 22 cases. This is the mortality. 9 patients died at 2 weeks, and 10 at 1 month, and another 8 within 3 months. So altogether, so at 2 weeks, 9 died. Between 2 weeks and 1 month, another 10 died. And between 1 month and 3 months, another 8 deaths. So the mortality is C 27 out of 110 is 24.5 altogether at 3 months, which is much better than what is mentioned in the literature, I suppose. So this is the age group. The youngest was 34. I have not included intraventricular hemorrhages here, so that is separate. So 34 to 78, average hospital stay 7 to 7.7 days, and 34 out of those patients needed tracheostomy because we did not have post-op ICU, HDU facility, and most of the patients already aspirated at the time of surgery. And also we know tracheostomy, it gives better pulmonary toilet. So in my experience, I think early tracheostomy in these critically ill patients have given some hope of life for them. And we have saved considerable amount of patients with ICH complementary thanks to this procedure, tracheostomy, especially as a peripheral neurosurgeon. So out of these 110 cases, 65 done under general anesthesia with endotracheal intubation, and 20 done under general anesthesia with an LMA. 18 cases with sedation plus local anesthesia, and 7 cases under local anesthesia only. So this is the outcome. This is the, as I said, the mortality is 24.5%, but I think I need some more cases for this data to be, if I want to publish these cases. So this data has not been published yet. And this is the modified ranking scale, 0 patients with no symptoms expected. 3 patients with no significant disability, 2 slight disability, 47. Most of the patients comes under this category in my case series, and moderate disability, 31, moderate to severe disability, 18, and bedridden patients, 11. And out of this, then you will ask me, what are the nuances and complications you had? I had 5 cases of rebleeding, and out of these 5 cases, 3 were operated within 24 hours of presentation. So I think it's not a good idea. It's not a prudent idea to advisable to operate ultra early within 24 hours. I think the best is to operate with between the 24 and 48 hours time. That's the best time period, I suppose. So I had 3 cases where I had to clip aneurysm, so I had to convert it to a craniotomy. Because getting a CT angiogram done in our setup as earliest convenience is not an easy task. So sometimes you had to go ahead, even though you don't have a CT angiogram, and in that case you had to be careful and you had to be precautious and you had to get ready with your armamentarium, clips and everything. AVM resection, as I said, 2 cases I had to resect the AVM. And 66% of these patients develop post-op chest infections. You can see, I mean, 2/3 of the patients develop post-op chest infections in our setup, which is the biggest problem in countries like us. 31% needed the tracheostomy as a life-saving procedure, actually, because of various reasons. And out of that, 2 patients died of tracheostomy bleeding and 3 patients died of post-op cardiac events. So what are the lessons learned? The lessons learned as a a neurosurgeon working in a poor resource center. So I feel it has a favorable outcome, an excellent option in low resource countries, because it does not need anything other than a good planning, a very well planned, gentle procedure, and the microscope. So you don't need the navigation, you don't need the endoscope because you don't have that. And you need these 3 T's. You need training because initially it's difficult. You need to have the tunnel vision. You have to get used to it. And you have to understand the extensions. Otherwise, you will end up in removing only 25 to 30% of the clot. And also, you must make sure that you won't make it even a bigger clot by operating. So you need to have training, you need to have the talent, and you need to have temperament as well. So you need to have the temperament. It's very important because it's technically not easy always. So you have to have a pre-op 3D picture in mind. It is very essential. You can't just go in and just take the clot out as it is. It's not the case. So you have to plan pre-operatively. You have to have a 3D picture in your mind, and then think about the entry point, where I'm going to enter, what is the best entry point, what is the trajectory, which is very important. Attack the clot, go in. If your entry point is correct, if your trajectory is correct, go in. You get into the clot, always attack the clot from inside to outside, as I always mention. Be prepared to leave a thin layer of anteromedial aspect. It doesn't matter. You don't need to have a post-op CT which looks excellent even without a drop of blood. No, the outcome is the most important. Don't chase the clot too far. The most important last step, I repeat and repeat, hemostasis. Take 10 to 15 minutes for the hemostasis and achieve an excellent hemostasis. High chance of pre-bleed if you don't achieve that. And remember to operate only if there is a good outcome predicted. If you don't predict a good outcome, what is the purpose of operating? What is the purpose of either hastening the pathway to the hell or the heaven? And why you add up the numbers to your own graveyard, right? You know, most as neurosurgeons, we maintain our own graveyard. So it happens. We can't avoid that. So operate only if the good outcome is predicted, especially in a country like Sri Lanka, a third world country where the resources are minimal, where you don't have a proper rehabilitation pathway. And what I have learned, the prognosis is poor if operated within 24 hours and best to operate within 24 to 48 hours. I think that's the best, the window for us to operate. And poor prognosis and outcomes are observed in thalamic ICH in my series as well. And remember, it's very important, outcome and the follow-up of these patients. You have to think about the outcome mainly and follow these patients up. Follow these patients at least a year, if possible. So it's not an easy task in a setup like my area, because you have to have the contact of these people and you have to follow these patients. It's not an easy task, right? It's very easy that your patient is missed after 1 month or 3 months. And follow-up is very important. It's more important than getting satisfied with the post-op CT. So it's not just operating on these patients and see the CT and have a look at the CT. Okay, I have done a great job. There is no blood in the CT. It's not like that. You have to follow these patients up. Think about the patient's outcome. That is the most important. You can have you might not have a fantastic CT, but the patient's outcome would have been good. The patient's outcome is you have done a good operation with regards to the outcome. So that is the most important thing. And learn, last but not least, when not to operate if you are in a poor resource country, as I mentioned, because in a country like Sri Lanka, it's very difficult to convince people that there is no point in operating in such huge massive ICH with brain herniation when they are presenting with the GCS of 3 with pupils dilated and brain herniating. Sometimes people expect us to do magic, but as far as I'm concerned, I'm not a magician. I always say I only operate if there is a good outcome, if I predict a good outcome with all my knowledge, and so that aspect is very important and very challenging in our setup, because sometimes our people want their, as I mentioned earlier, their relative, even in the vegetative state, if the patient is physically there, they're satisfied, but that is not going to cause any good for the family, because I have seen so many cases where the families are disrupted. I mean, when there is a disabled patient, stroke patient, so they are financially, they are lost, the social background, I mean, socially, the social status goes down. So everything is affected, but they only realize it after some time, not at the very beginning, where they are very emotional. So most of our people are very emotional. So when we ask to manage this patient conservatively, or rather we say to palliate, it's very difficult. In that case, what they do, they take the opinion from a different surgeon, they get the second opinion. And I have seen, there were instances I have seen in some cases when I say cannot operate, not operable, because of various reasons. And then they seek the second opinion, and they go to private sector, do something, you an EVD or whatever they do, and then get into more trouble. So that is another aspect you had to think about, especially when you are working in this part of the world and in a poor resource country. So that is what all I have got. And I suppose I have given you a satisfactory description of what I have done up to now, what I'm going to continue as well. So if you have any questions, you can ask me.
Very good, Surat. Thanks for taking the time. Let me get off the screen share here. Hold on. Okay, we have a couple of neurosurgeons on the panel, and I just interrupted someone. Go ahead. Who was? Go ahead, Saeed. How you doing?
Hello. Thank you very much, Surat, for this very interesting presentation, and congratulations for what you do, because it's not easy. It's not easy. The most difficult is to work in such condition. And what we must know to work in this condition needs a strong, solid, strong formation in neurosurgery. It's an important point. And I congratulate, my congratulations, because you work without intensive care unit, but you do a great job. For the intracranial hematoma, you use the microscope. It's very interesting to do it with microscope, if we have the possibility to have a microscope. And with the microscope, we can turn on the left and the right with the operating table, also to see the different angle. So you need to move on the right and the left, front and the back, to use all the possibility of the microscope. So I have nothing to do to add. It's a great job, and I congratulate my congratulations too, because you have a statistical study analysis. It's very, very important for a young neurosurgeon to know the progression and the different of the different pathology, and you can talk with statistic, you know. So it's very interesting. Congratulations, my friend.
Thank you very much, Dr. Taha. I completely agree with you. And thank you very much. Yeah, it's been a great inspiration for me. So I expect to publish this data, but I think I need more data and more cases. So more the cases, I think more the validity. So we'll see how it goes.
Oh,
thank you very much for your kind comments.
That's very interesting, and congratulations. We are proud to see a young neurosurgeon work in this condition. It's not easy. I know it's not easy for you.
Thank you very much.
Yes, Sarath, they don't teach these things in medical school, right? The financial part of practice, as well as the being faced with lack of equipment. You learn about what you should do with certain equipment, but then you get out in the practices and say, I can't get it. I've got to make do.
Yeah, exactly.
So, okay. Ahmad, do you have any, Ahmad, by the way, Saeed, do you know Saeed? He's a neurosurgeon from Reunion.
All right.
Off the coast
Nice to
of
see you.
Africa, the East Africa.
Okay. Professor Surat, thank you very much for your nice presentation and congratulations. As I told before to Professor John Bennett and Taha about that we are the same in Afghanistan. We are facing challenging with neuro anesthesia, and we also do local anesthesia as well, and we all have problems with ICU care, and neuro ICU is also a problem in Afghanistan, and we haven't also no navigation system in Afghanistan as well. And we learned a lot of your experience. Thank you very much. Congratulations. It was good. And I would like to have communication with you and exchange our experience as well. Thank you.
Sure. Thank you very much, Dr. Fawad. Thank you very much for your kind comments. Yeah, I think it's a very common problem. I mean, within this part of the world, and especially ICU beds. So that's why we had to do early tracheostomies and take these patients to the ward prematurely. And maintaining the blood pressure is a big problem, because in the ward you can't use these hi-fi stuff to lower the blood pressure. And I usually try to maintain the systolic blood pressure less than 160 or ideally 140, but that is not practical always. So we have seen patients rebled after surgery, but fortunately, that's why I'm always trying when I'm operating, take time and achieve as much as hemostasis. But there are times, even how much you do, there have been cases that the blood pressure shoots up, and there has been cases of rebleeding. So yeah, that's how it goes, I think, in our part of the world. So we had to find out solutions.
Okay, thank you. Thank you, Professor John. Thank you, Professor Surah.
Yeah. Excuse me, Ahmad may do an Afghanistan neurosurgery grand rounds.
Yes,
once we get around to it, right? That's
we are planning to do it. Yes.
Great. That would be fantastic.
We share with you, inshallah.
That's great. Sarath, yeah. I guess, Sarath, you probably have to do a lot of medical management, right? I mean,
of course,
most of the medical management you probably have to do on your own, right?
Yeah, of course. I mean, there are so many cases. I mean, every day we get 2-3 cases of intracerebral ICH where the all these patients being managed medically in the medical ward. So we had to transfer the patient back to the local hospital for the medical management. So in our part of the world, in Sri Lanka, in my area, we are seeing so many intracerebral hemorrhages, especially these hypertensive hemorrhages. So it's not uncommon. It's very common. So maybe around say 5 cases per day. So that's around 100 to 150 cases. Around 100 cases per month we see intracerebral hemorrhages. So only a small percentage is being operated. and a lot of medical management is involved. So sometimes we had to do it by our own. We get medical opinion as well, but most of the time, once the patient is operated, it's mainly us. We are doing the management. It's not easy.
Yeah, what are the most common medical problems that you have in post-op?
Yeah, as I said, the most
neurosurgery.
Yeah. Mostly chest
common?
infection. Yeah, post-operative chest infection. Yeah, post-operative chest infection. That's the most common and most problematic, most troublesome. So it's very difficult to get rid of these chest infections when it is established. So IV antibiotics, a lot of cost. So nowadays we don't have antibiotics as well. So it's being a big problem for us. Mostly due to aspiration.
Oh, okay. So you have to do a lot of research on antibiotics and sensitivity.
Excuse me, Surat. Yeah. I want to know the cause of infection because they leave early they leave the hospital early, or what is the problem?
The main reason what I have noticed is the aspiration, because sometimes in other wards, when they have been managed, due to the lack of proper care, NG is inserted, so they overfeed the patient, and their bystanders feed them even though we ask not to feed them, so they get aspirated, these patients with reduced conscious level. So it's beyond our control. It's not very easy to educate all these patients, and in other wards they can't manage patients who are tracheostomized. So only our ward, in my unit I don't have a separate ward. It's just a corner of the orthopedic ward with 6 male beds and 4 female beds. So we have a dedicated set of dedicated nurses, 5-6 nurses who were trained for tracheostomy care and for neurosurgical patient management. So it's with this limited staff we are managing these patients. So even in our wards, there is a high risk of aspiration. So that is the most, the most problematic aspect of all these patients. And sometimes when they are coming from the ICU, they contract this ventilator-associated pneumonia. Very difficult to get rid of.
Well, this is not an official statement, but that some nurses are very good at managing medical conditions, and all you need is a signature from the doc. They get experience, and they know, and they'll call you and say, "Hey, doc, I think you better do this." They really help. A good nurse really helps. Okay, more comments or questions from anybody? Anybody want to introduce themselves? No, that's okay. Okay, Surat, we were talking before the broadcast, and we might do a Sri Lanka Grand Rounds every 2 weeks because it's doable twice a month, and it doesn't have to be a extensive broadcast. It can be just basically a case history or some kind of didactic point of view that the neurosurgeon feels they want the neurosurgery world to know about. And certainly
I think a weekday is convenient for you, John, is it?
Every week?
No, I mean a weekday, every fortnight.
Yes, well, I think we can develop a following at that. The weekends it's really hectic. Online. But I think Monday, Tuesday, if we establish it's going to be this time, and there's no competition, because you talk about competition. It's not in medicine, but it exists online. There's less broadcasts during the week.
Are you comfortable on a Thursday?
Thursday, I have one already, but yeah, let me work on a time. I do. We do one from Mexico, which would be 7 o'clock. Yeah, I think that would work. That would work.
Sure,
yeah, Thursday would work.
Thank you. I'll keep in touch with you, John. Thank you very much for giving me the opportunity again. Right.
Okay, it's great. I love your background too. It's really nice. Okay, thanks.
Thank you.
Come on, Saeed. Ahmad, thank you.
Thank you.
Thank you. And I don't know if you want to say, Mariam, are you there?
Hello.
Yeah, Maryam
Hello.
is an active person in the mentorship webcast from Iraq.
Okay.
Hello. I'm Mariam Najir Awadi.
Hi, Mary.
Recently graduated from Baghdad University College of Medicine, and I'm have so interesting about neurosurgery. So I'm so thankful about this presentation of this meeting. It was very helpful and inspiring and insightful about this explanation and all of these videos. And I don't forget to thank a big thanks for Dr. John for this opportunity to see us and see this this all experience. And I'm so grateful to sharing with us this experience, a worthy experience. So I'm thankful and really appreciated it.
Okay, very good.
Thanks, Mary.
Yeah, they have a very good mentorship program with Samar Hose on Saturday at 3 o'clock. He runs a great mentorship for neurosurgeons to be. At any rate, okay, thanks everyone for coming. And we'll just, I'm going to end the broadcast, but stick around to network, and we'll be in touch, Sarat.
Sure.
Sarat, okay?
Yeah. Sure, John.
Thank you.
Thank you then. Bye.
Yeah, very much.
Okay, we're off the net. So, yeah, Marianne, meet Saeed. Saeed is from Reunion. She wants to meet some neurosurgeons. Marianne, are you there?
Yeah, Miriam.
Yeah, this
Hello.
is Saeed. He's from
Hello.
Reunion. Reunion. I
Hi,
bet you don't
from
even
another
know where
world.
that is. I didn't know where it was.
أهلا وسهلا.
أهلا وسهلا. You are speak Arabic.
Yes,
Ah.
yeah.
Where are you from?
I am from Reunion Island. It's an island near Mauritius. It's a French department. In oh yes, it's overseas department, French overseas department.
Nice. You are speak Arabic fluency or just some words?
لا بتكلم عربي.
بتكلم عربي.
Where'd you learn that? Where'd you learn? Did you
Yeah.
train? Did you train? Where'd you learn that, Saeed?
What?
Arabic.
Excuse me?
Where'd you learn Arabic?
Because I'm originate from Morocco.
Morocco.
Oh, okay. That's the
Yes,
first
yes.
language of Morocco?
Yes.
French and
And,
Arabic.
French
and,
and Arabic. I think so.
I don't know. Excuse me. I don't
French
understand.
and Arabic, yeah, your language in Morocco, I think so.
French and Arabic, yes. French and Arabic, yes.
Yeah.
Yeah.
I get some French words.
Yeah.
Some like this. Yeah.
Bonjour. Like bonjour.
Bonjour. Comment tu t'appelles?
Saeed, yes.
Speak
So
French.
Reunion Island, it's near Mauritius, and we have a big unit of neurosurgery and with a great intensive care in the island, and we cover all the area of Mauritius, Madagascar, and the Comores too. We have a great population, and we treat all the cases, pediatric, vascular, traumatology, tumoral. We do all the operation, and we have all instruments like neuronavigation, OR. We have in the island more than 15 MRI. So it's
great, mashallah, great.
Yes. That's
there's your island, Saeed.
Yes.
Sarat,
I am in the south of the island here in Saint Pierre, like in south. Yes, we have Mauritius on the left, Yeah,
Let me get a wider view there.
yeah. Madagascar.
Yeah.
Yeah, we are here. A small
Oh.
point.
Sri Lanka up here.
Yeah, small point.
Yeah.
You guys are neighbors.
Yeah.
Yeah.
You can
Very
take a walk, you
interesting.
can take a boat,
So,
a boat
we
ride.
cover all this area in the east coast of Africa. From Mauritius, Seychelles too, we have the patients from Seychelles too. Madagascar, Comor, it's a French department. It's another French department. Mayotte, like it's Mayotte, another French department is a Comorian department, but they chose to still with the French.
Do you cover Mauritius? Their neuro cases, or do they have someone
We
that
work
handles
with the Mauritius, yes, because they are in the Commonwealth. They
Right.
stand in case when it's not an emergency, they go to England or Australia. But when there are cases with emergency, they come to us.
Okay, very good.
Said, can I ask you a question? How many neurosurgeons are there in your country?
Look, we are 6 neurosurgeons.
Okay,
Or
great.
near
All from France, all from France. The neurosurgeon from France.
yes, yes.
Okay.
Yes, 900,000 population.
Population. Okay,
6 neurosurgeon.
right. Okay.
Mm.
Do you
That's
have
not-
this navigation and all?
Yes, we have two station S7 and S8,
Oh,
and we have 4 microscope with Kinevo, Pentero. We have the endoscope. We do endoscopic surgery.
oh, great.
Yes, hypophysal and skull-based surgery. We do endoscopic and all the other
What about the
operations.
Madagascar? What about the Madagascar then? Are you more equipped than Madagascar, or is it
No,
the same?
they come to us because in Madagascar for right now they have not the unit intensive care. They have not all what we have. We need to do neurosurgery. So we are trying to work together. I have contact with them to create a collaboration for residents.
Madagascar.
Because they are so close. So it's important to do this collaboration because the young nurses can come back to their country, you know, because when they go overseas, United States, Europe, they don't come back.
Ahmad, are you there? Ahmad,
Yeah.
Ahmad, are you there? Ahmad? Let me see if we can show us around Afghanistan where he's at. Ahmad, are you there? Perhaps he stepped away. Let's see, there's another person. Oh, hold on, let me. Sabangu, are you there? Can you hear me?
Yeah, I'm there.
Where are you from?
Good evening to everybody.
Good evening.
Benin.
Good evening to everybody. Good
Let me see
evening.
Good evening.
Good evening. Good.
I'm a Congolese medicine, but
Let
now
me see.
France,
Benin, right?
Congolese.
Oh, Congolese with
Congolese.
Dr. Kabulo.
Yes, I know him. He is the big neurosurgeon in my country.
Okay, let me, can you see the screen share?
I don't see the screen.
You can see the Congo, right?
Yes.
Yeah.
Okay,
Yeah.
which part of the Congo are you in, Republic or Democratic Republic?
Yes, I'm from Democratic of Congo.
Oh, okay, which
now
part? Are
I'm
you
at
in
France.
Lumbashi, Burundi, or where are you at?
From Kinshasa, the capital, the head
Oh,
of country.
Kinshasa, it's on the border of Republic.
Yes. Oh, Kinshasa, the head of country.
Oh,
The
yeah, that's
head.
the capital, right? Probably?
Yes, the capital, yes.
Okay,
And now I'm at France, where I do my resident of neurology.
oh, okay, and then you're
Yes.
gonna go back,
Perhaps.
perhaps, okay.
Okay.
Leave it open, right? How far along are you in your residency?
Okay. I'm very glad to be with you at this Zoom each week.
Great, you're welcome
Yes,
to come to them all.
it is a good place to share our experience about neurology and neurosurgery.
Yes. Yeah,
Okay.
we love to broadcast anything, any ideas you have. And that applies to everybody. Just like we're doing with Sarath, just, hey, we want to do a webcast, let's do it. Let's do it.
Okay.
So, Dr. Kabulo, I guess, do you see him very much? Is he in Kinshasa, Dr. Kabulo?
I don't see him anytime. I don't see him. But I know
okay.
that in Congo there is a big neurosurgeon who was at Lubumbashi now, or Burundi or Zimbabwe, perhaps.
Yeah, I haven't, he's been very quiet lately, but he's very active usually in broadcasting.
Okay.
So,
It will be good to speak with him, especially about my hope to be a neurosurgeon after my neurology.
yeah, sure, yeah. This is a good way to meet them online. Gone are the days you had to, fly to meet somebody to communicate effectively.
Okay,
Of course, you could.
it is a good idea.
Well, you can always fly later to see him, but initially, the initial contact, that's what I'm trying to show Marianne and all the students. It's a great way to meet people where you want to train or whatever. It's a great way.
Okay,
I just wish they
right.
had it
Thank
when I
you.
was in medical school.
Please.
I wish they had the internet when I was in medical school. Right, Marianne?
Yeah.
Students are lucky, very
Yeah,
lucky today. Very
I
lucky.
agree. I agree. I'm so lucky to join with you. I'm so lucky. Yeah, I agree.
It's a great tool. So you'll see. You'll see. So, okay, I gotta get ready for the next webcast, and thanks everybody for coming.
Okay, thank you.
Thank you.
Thanks,
Bye-bye.
John.
Thank
See you
you.
next time.
Bye.
Bye-bye.
Bye.
Bye.